Hello friends. So today we are going to study neonatology. One of the very important topic, one of the most important topic in neonatology is respiratory distress syndrome. Respiratory distress syndrome has been asked multiple times in all the exams. In all the exams like NEET PG, in MCI, in every exams. So today we are going to deal with respiratory distress syndrome. Before starting or before knowing about respiratory distress syndrome, it is important to know about surfactant. What is surfactant? Surfactant is produced from type 2 alveolar epithelial cells. It is very important point. Alveolar epithelial cells lines the alveolar surface. Okay. So, what is the function of surfactant? Surfactant prevents the alveoli from collapse, okay, during the process of expiration. And how? It decreases the surface tension. So what does surfactant does? Surfactant decreases the surface tension and prevents the alveoli from collapse during the expiration. It is very important point. You have to know this, that surfactant prevents the alveoli from collapse. Okay. And what is the composition of surfactant? It is made up of phosphatidylcholine, phosphatidylglycerol, sphingomyelin, and surfactant protein ABC. Okay, guys. But you have to know that phosphatidylcholine is also known as lecithin. So in MCQ it is not asked phosphatidylcholine nowadays. They ask lecithin. So you have to know their percentage, that it is 75%, and phosphatidylglycerol is 20%. Now, when does surfactant appears in lungs? It appears during the 20 weeks of life. Firstly, it appears as a lamellar body. Okay, in amniotic fluid we can see it at 28 weeks of life, and mature surfactant gets mature or mature concentration appear in lungs during the 34 to 35 weeks of life. Now, how will we assess the lung maturity? On the basis of surfactant, we find the lecithin sphingomyelin ratio. If it is greater than 2, there is normal lung maturity. If it is less than 1.5, immature lung is there. Secondly, we do the SEC test. Positive SEC test is normal lung maturity. Negative SEC test is immature lung. Then we find the phosphatidylglycerol assay, lamellar body content. I have told earlier that it is stored in the lamellar body. Okay, during the 20th weeks of life. Now, if in the lamellar body, if the content is less than 15,000 international units, then it is immature. If more than 50,000, less than 15,000 and more than 50,000, then it is mature lung. Now what happens during the surfactant deficiency? Alveolar collapse occurs. That we know. What happened to the lung? Atelectasis. That condition is known as atelectasis. What happens after that? Due to lung collapse, if the lung is collapsed, there will occur hypoxia. Oxygen will be less in that part. Then there will be inflammation of that part. There will be pulmonary edema. Now what happened? There occurs damage to the alveolar epithelial cells. Normally, if there is hypoxia, there will be damage to the alveolar epithelial cells. If there is damage to the alveolar epithelial cells, then the proteinaceous material will be leaked from these alveolar epithelial cells, and they will enter into the alveoli. This proteinaceous material is known as hyaline membrane. Okay. Now I will tell you what are the type 1 and type 2 alveolar cells. In this photo we can see that type 1 and type 2 alveolar cells. So surfactant is produced from the type 2 alveolar cells. Now this X-ray shows what is atelectasis. This part, lung is collapsed. This part, lung is collapsed. Now, what is the incidence? Incidence 4 to 7% of all neonates. It is most common in preterm. Respiratory distress syndrome is more common in preterm, 30%. Postterm and term. Also, it is seen in postterm and term. And National Neonatal Perinatal Database of India has defined respiratory distress as presence of any two of the following features. It is important definition. This you have to know. If the respiratory rate is more than 60 per minute, but before this you have to know that respiratory rate is different for the different age group. We know that for adult it is 16 to 20. Okay, Somewhere it is written 12 to 20, 14 to 20 or 16 to 20. But for the newborns, neonates, the range of respiratory rate is different. That I will telling you later. Then other finding is subcostal and intercostal recession, expiratory grunt and groaning. Okay. Remember, I will be posting videos of respiratory distress in my YouTube and also in my Instagram page with the same name, Paeds Made Easy. So you guys have to follow it to see those videos. There are also multiple MCQs, and also where there are multiple X-ray and photos and also mnemonics. And on Instagram, you guys should follow the page. It will be helpful for you guys during your NEET PG or MCI preparation. So other signs which are important are nasal flaring, supraesternal retraction, decreased air entry on auscultation. Now what are the common causes of respiratory distress? Remember these above features of respiratory distress. Respiratory rate is more than 60, subcostal and intercostal retractions, expiratory grunt will be seen, nasal flaring will be seen, supraesternal retraction will be decreased air entry on auscultation. Now what are the common causes of respiratory distress? Respiratory distress syndrome due to surfactant deficiency has overall incidence of 1.2% among all the neonates in India. It is more common in very low birth weight baby. These are the common causes of respiratory distress. These you have to mug up. Some are like airway, due to airway disorders like conal atresia, laryngotracheomalacia. These are causes of respiratory distress. Other causes can be pulmonary disease like TTN, respiratory distress syndrome, meconium aspiration syndrome, pneumothorax. I will be teaching all these features separately. Cardiac disease like congenital heart disease, arrhythmias, this can also lead to respiratory distress. Sepsis, anemia, polycythemia, all these can also lead to respiratory distress. Now, some problems in mother can also lead to respiratory distress syndrome. This you have to know. Like if the mother is diabetic, the child can have TTN, child can have respiratory distress, hypoglycemia can occur, large for date can be there. If the mother has PIH, if asthma or sepsis, polyhydramnios, so these mothers can cause respiratory distress in their children in newborns. Important is surfactant protein B deficiency. This you have to learn because it has been asked in MCI. If one sibling has respiratory distress, then the other can have respiratory distress due to deficiency of surfactant protein B. Now, intranatal causes. What are intranatal causes which can lead to respiratory distress? Prolonged rupture of membrane. These all can produce sepsis. Chorioamnionitis and prolonged rupture of membrane. These can cause sepsis. Okay, or meconium aspiration syndrome can lead to respiratory distress. Now, how will we assess a child with respiratory distress? You have to do inspection. There are, for all the examination, 4 points are important: inspection, palpation, percussion and auscultation. These 4 things are important for all the systemic examination of all the systems. So in everywhere we are going to deal with inspection, palpation, percussion and auscultation. Okay, so in inspection we will see the respiratory rate, we will be seeing the symmetry of the chest movement and its synchrony with abdominal wall movement. We will be seeing the color of the movement, pink or cyanosed, and we will be seeing the oxygen saturation. Okay, now I have told that respiratory rate is different for different age group. For less than 2 months the respiratory rate is 30 to 50. If it is more than 60, it is known as respiratory distress. For 2 to 12 months, it is 20 to 40. If it is more than 50, it is known as respiratory distress. If 12 months to 5 year, rate should be 20 to 30. If it is more than 40, it is known as respiratory distress. Similarly, for 10 years, 15 to 18, it is more than 30, it is known as respiratory distress. Okay. So, important respiratory signs you have to see. Now, remember the normal respiratory rate in a child less than 2 months. If it is more than 60, 20 to 40, 20 to 50 is normal. 2 to 12 months, 20 to 40 is normal. It is asked. I will be showing you an MCQ where they have given just this. Respiratory rate is higher. Now, again, what are the other important respiratory signs we are going to see? Tachypnea. Normally respiratory rate higher than the normal. Apnea. What is apnea? This is an important topic and we'll be dealing it separately. It is cessation of breathing by a newborn. I'll be dealing this. Nasal flaring. What is nasal flaring? There is widening of the ala nasal while breathing. This is known as nasal flaring. What is grunting? Grunting is expiratory noise produced due to closure of the glottis. It is protective mechanism which neonates increases to prevent alveolar collapse during expiration. What is PEEP? Positive end expiratory pressure. The neonates, while dilating the alar nasai, increases the PEEP, which prevents the alveoli from collapse. So it is a protective mechanism, but it is one of the signs which shows that the child is having respiratory distress. Other signs are retractions, stridor. What is stridor? Stridor occurs due to narrowing of the upper airways. It is a sound which is produced due to narrowing of the upper airways. It can be both expiratory or inspiratory, but mostly it occurs inspiratory. What is wheeze? It is the mucosal expiratory sound due to narrowing of the small airways. Okay. What are we are going to see in palpation and percussion? This was inspection. The above features which I told you all was in inspection. Now we are going to see inspection and palpation and percussion. In that we will see in the position of the trachea. Normally in a collapsed lung, in consolidation, in pleural effusion, the position of the trachea changes. This we have to see. We have to see the localization of the apex weight. We have to see the apex weight. It also changes with any problems in the lungs, like pleural effusion or any consolidation. It will also change. Now we have to see that on percussion there is dullness is there. It is seen in consolidation and collapse. This you have to learn. Very important. It comes like in MCQs. If there is stony dullness, it is seen in pleural effusion. If on percussion there is hyperresonance lung field, it is seen in pneumothorax. Remember, normal is resonant, but if it is hyperresonant means more air is there. It is pneumothorax. Okay. Auscultation, we have to see air entry. We have to see the air entry or any added sound like wheeze or stridor. Okay. Now we will be seeing respiratory distress scoring system. There are two respiratory distress scoring systems which are very important. One is Silverman-Anderson, other is Downey's Vidyasagar score. Okay, there are photographs also. I will be showing just below. So now, what is Silverman-Anderson and what is Vidyasagar score? In Silverman-Anderson, we grade the child and we do the scoring. So, like, we have to divide it in 5 criteria: upper chest, lower chest, xiphoid, nares, external nares, and grunt. And we define that it is synchronized, there is no retraction, or if the xiphoid is retraction is present, and we score on the basis of this only. Okay. So at your level, you have to learn that there is Silverman-Anderson score for chest retraction and respiratory distress, and there is Downey's score. Remember, they are not giving now Downey's score. They also write like Vidyasagar score. Okay, so you have to know what is Downey's and what is Vidyasagar score. In Vidyasagar score, there is cyanosis, retraction, grunt, air entry, and respiratory rate. And in Silverman-Anderson, there is upper chest retraction, lower chest retraction, xiphoid retraction, nares dilation, and respiratory grunt. All these 5 points should be known by you guys, because they give you anything and they will say whether this belongs to Downey's or not. Suppose they write cyanosis, retraction, grunting, and upper chest retraction. You have to find out the odd one. Okay. Now the scoring. If the score is between 0 to 3 in Silverman-Anderson, it is mild respiratory distress. If it is 4 to 6, it is moderate respiratory distress. If the score is greater than 6, it is impending respiratory failure, and if it is more than 10, there is severe respiratory distress. On the basis of this, we plan the treatment of a child. We have to put the child on CPAP, we have to put the child on ventilator support, this or just on oxygen. We have to plan this on the basis of these Silverman-Anderson score and Downey's score. Okay. Now, what other investigations we are going to do? We do gastric aspirate sake test. Okay. We do trans-illumination test. We do X-ray chest. We do USG chest, and we can do arterial blood gas analysis. So one of the most important thing is shake test. What we do in shake test? We take a test tube, we take 0.5 ml of gastric aspirate by NG or OG tube we take out, and then we add 0.5 ml of absolute alcohol. Okay, that is 95% of ethyl alcohol. We keep in test tube and then we shake the test tube for 15 seconds and we leave for 15 minutes. Remember, 15 seconds and 15 minutes. Now we see air bubble. If there is entire rim of the bubble is present, then it is a positive test. Absence of bubble is a negative test. Incomplete rim of bubble is an intermediate test. Okay, sensitivity of this test is 70%. Remember, if the absence of bubble is a negative test, important. On the point which I am highlighting is important MCQ. Presence of entire rim of bubble is considered as a positive test. Now we do trans-elimination test. We see for any pneumothorax index. We do X-ray chest. What we do? AP view and cross-table lateral view. USG chest can be done to check for effusion, pneumothorax, and arterial blood gas analysis is one of the important things. Now what we will do? We'll be doing. Now we have to plan the treatment. That we will plan on the basis of all these investigation and the condition of the child. It can be we can just give warmer or incubator, or we can put the child on oxygen by nasal pronge, hood, mask, or CPAP on ventilation, or we can give the child surfactant. For surfactant, for ventilation, for CPAP, all these I am going to make a separate video. So you guys have to follow my YouTube channel and my Instagram page for regular updates. We will be dealing in these channel, in these pages about MCQs, and these notes are helpful. Now the most important thing, the MCQ. This we will discuss. Just tell me one thing. This 3-month-old child with indrawing of chest with respiratory rate. So our MCQ, the first one, 3-month-old child with indrawing of chest with respiratory rate 52 per minute. This was asked in NEET. What the condition is? Surge, tachypnea, respiratory distress, or ARDS? So the answer is respiratory distress. Why we say? Above I said that any of the two criterias. Okay, let's go above. Any of the two criteria. Okay, just a minute. This one. Respiratory rate more than 60, subcostal intercostal retraction, grant. Now respiratory more than 60 was just a criteria, but on the basis of age group you have to say. For a 3-month-old child, the respiratory rate more than 50 was said as respiratory distress. Okay, and second was chest indrawing was present. That means two criteria are fulfilled, so it is known as respiratory distress. Second question. 9-month-old child with respiratory rate 53 per minute. Similarly, for 2 to 12 months, the respiratory rate more than 50 was considered respiratory distress. So here the respiratory rate is more than 53. So it is tachypnea. Tachypnea is confirmed, but there is presence of cough. There are no other features like subcostal retraction, grunt, or nasal flaring, any other feature. So we will not say it as respiratory distress. This comes into tachypnea only. So you have to know the catch in this question. They have just changed the question. Okay, so you guys have to know this, that if there are those two criteria are not fulfilled, then it is not respiratory distress. It is just tachypnea or any other thing. It can be ARDS, but for respiratory distress syndrome you have to fulfill those two criteria. Okay, now there are some X-rays. This is whiteout lung. You have to know this. Whiteout lung. Okay, this is air bronchogram in pneumonia. What is air bronchogram? It is a phenomena of air-filled bronchi. This being made visible by opacification of surrounding alveoli. Okay, so this you have to know what is air bronchogram. It is air-filled bronchi being made visible by the opacification of the surrounding alveoli. Okay, now air bronchogram. Then what is ground glass opacities? There is reduced volume and transparency of the both the lungs, so we call it that ground glass opacity. What? Reduced volume and transparency of both lungs. Okay, now what is reticulogranular pattern? These are few x-rays which are important in respiratory distress syndrome, like uniformly distributed hypoaerated lung. It is hypoaerated lung, aerated lung, which is uniformly hypoaerated. Okay, so you guys have to know this. Then we are done with the x-rays, some basic x-rays. Remember, we would be dealing with the treatment part like ventilation, CPAP, apnea, everything in separate videos. In a single video, it won't be helpful. So I will be making small videos for you guys, and I will be posting it on my YouTube channel. Also, I will be posting these notes on my Instagram page. So kindly follow this and give a like button.